Good morning. My name is Dr. Ankeet Bhatt. I'm a cardiologist and clinical investigator at the Kaiser Permanente San Francisco Medical Center and Division of Research in San Francisco, California, and an adjunct professor at the Stanford School of Medicine in Palo Alto, California. Today, I'll be presenting a case of a 62-year-old male with symptomatic NYHA Class III heart failure, type 2 diabetes, and hypertension presenting with exertional dyspnea. His current medication regimen includes metoprolol succinate 50 milligrams daily, spironolactone 25 milligrams daily, pioglitazone 15 milligrams daily, and losartan 12.5 milligrams daily. He has a history of an episode of angioedema just over a year ago that required both epinephrine and steroids with no clear inciting event or agent identified. A transthoracic echocardiogram 3 months ago showed a left ventricular ejection fraction of 35%. An ECG obtained today in the clinic shows a sinus rhythm, a heart rate of 70 beats per minute, and a right bundle branch block. He's had a prior coronary angiography showing non-obstructive coronary artery disease. Today on physical exam, his jugular venous pressure is flat. There's no significant peripheral edema. And we're asked to identify what the next best step to improve the patient's heart failure-related quality of life and morbidity and mortality. So let me take you through this case. The patient currently has a symptomatic heart failure with reduced ejection fraction and comorbid type 2 diabetes and hypertension. As you know, in patients with heart failure with a reduced ejection fraction, there's class 1 recommendations for 4 classes of medical therapies. These include an evidence-based beta blocker, including metoprolol succinate, bisoprolol, or carvedilol, a mineralocorticoid antagonist such as spironolactone or pioglitazone, a ACE or ARB, and in patients who are able, up titration to an angiotensin receptor neprilysin inhibitor, sacubitril valsartan, and an SGLT2 inhibitor such as empagliflozin or dapagliflozin. In this case, our patient is already on an evidence-based beta blocker, metoprolol succinate, spironolactone, an MRA, and losartan, an ACE inhibitor. In order to optimize the patient's quad therapy for heart failure with reduced ejection fraction, we are left with 2 incipient medical options. The first being transition from losartan, an ARB, to sacubitril valsartan, a angiotensin receptor neprilysin inhibitor. Let's dive into the evidence here. In the Paradigm heart failure trial, which studied symptomatic patients with heart failure with reduced ejection fraction, compared a strategy of sacubitril valsartan versus an ACE inhibitor, enalapril. In that trial, there was a strong and consistent reduction in clinical events amongst those randomized to sacubitril valsartan versus enalapril. And clinical practice guidelines now recommend an ARNI over an ACE or an ARB in symptomatic patients with heart failure with reduced ejection fraction. So this seems like a potential viable strategy for this patient. However, importantly, the initiation of sacubitril valsartan is contraindicated in those who have a history of any angioedema. So in this case, given the patient's prior history of angioedema, the initiation of sacubitril valsartan to replace losartan would not be appropriate. Now let's dive into the 4th pillar of heart failure with reduced ejection fraction therapy, the SGLT2 inhibitors, or the sodium glucose cotransporter 2 inhibitors. These are drugs like dapagliflozin and empagliflozin. Both have been studied in large international randomized clinical trials, namely the DAPA-HF study and the EMPEROR-Reduce study, which looked at the efficacy and safety of dapagliflozin and empagliflozin respectively, compared to placebo in patients with heart failure with reduced ejection fraction. Both trials showed a remarkably consistent benefit amongst patients randomized to the SGLT2 inhibitor in terms of reducing heart failure-related morbidity and mortality and reductions in cardiovascular mortality. In addition, these therapies improved heart failure quality of life and therefore are widely recommended by the clinical practice guidelines in support of patients with heart failure with reduced ejection fraction. So clearly, based on the most recent ACC, AHA, and ESC guidelines for the management of heart failure, the patient should be on an SGLT2 inhibitor. Now, the patient is also on a pioglitazone 15 milligrams daily, which is a class of glucose-lowering therapies called TZDs. In the most recent clinical practice guidelines, TZDs are recommended against in a class 3 recommendation because certain TZDs may increase the risk of heart failure hospitalizations in patients who are at risk or who have heart failure. In this case, in a patient with diabetes, a simple switch from a TZD, discontinuation of a TZD, and initiation of an SGLT2 inhibitor may promote decreased mortality, decreased morbidity, improved quality of life in this patient with heart failure with reduced ejection fraction and type 2 diabetes. Finally, let's talk a little bit about device-based therapies. We have two major device-based therapies for patients with heart failure with reduced ejection fraction. An ICD, which is intended to prevent sudden cardiac death in patients with an ejection fraction of 35% or lower on optimal guideline-directed medical therapy. In this case, the patient has not yet been on optimal guideline-directed medical therapy because they are eligible for, but have not been initiated on an SGLT2 inhibitor. In addition, ICD therapy does not necessarily improve heart failure-related quality of life or morbidity, but does decrease mortality. Finally, cardiac resynchronization therapy is indicated in patients who have a persistently low left ventricular ejection fraction and a left bundle branch block on ECG with a QRS duration at least over 120 milliseconds and with a class 1 recommendation over 150 milliseconds. In this case, the patient has a right bundle branch block and therefore would not be a good candidate for CRT therapy. In particular, the patient should be optimized on guideline-directed medical therapy for their heart failure with reduced ejection fraction before consideration of device therapy. In summary, in this 62-year-old patient with heart failure, symptomatic heart failure, and a reduced ejection fraction, a switch off of a potentially inappropriate medicine, pioglitazone, to start a guideline-supported, clinical trial-supported medication in an SGLT2 inhibitor would provide the next best step to improve the patient's morbidity, mortality, and quality of life. Thank you very much for your attention.